one of the four divisions of Carenodes. And what we focus on here is we want to make sure that we are on the same page in terms of healthcare business. So what are you going to get from this meeting? Or, yeah, it's a meeting symposium. Essentially, you're going to understand in very clear terms where healthcare money comes from and where you fit in that overall picture, right? So this is really designed for healthcare entrepreneurs with, they can have healthcare experience, but this is really for those who come from different sectors and have a contribution to make to healthcare. But it's such a difficult environment to operate that the learning curve could be a killer for a startup. It could be a death sentence for clinicians, right? Clinicians spend all this time going to school and, learning what they have to learn to, be clinicians, but the business side is a missing element. For students in healthcare administration, I have a master's in healthcare administration, I have this and that credential. It's really not that important. I'd never sign an email saying, I have this and that credential with 4.0 here and there. No, because what I've learned has really brought me to where I am, which is a successful point, certainly much more to go, has really been on the job, right? It's been on the job, hands-on training, because healthcare is very personal and its administration is also very personal and nuanced. So there's no blog that's going to tell you what you need to know. And so let's bend that learning curve very quickly before you have to leave, so that you're not surprised, paralyzed, and discouraged. Okay, cool. So a little bit about me. The sound you should not be. Do you guys hear a sound when because this has music and you shouldn't be hearing that. So essentially, what it is that I want to do is share with you my background just briefly. Essentially, I come from a long line of healthcare administration background. My background comprises of, I was managing clinics across California and Texas. After that, we're providing primary care, substance treatment, and mental health across several counties and states. Like I said, California and Texas. Thereafter, Cardinal Health essentially recruited me to oversee 14 hospitals across in Southern California region. And essentially, these were 12 Dignity and 2 HCA hospitals. And essentially, my responsibility was to manage the post-acute network and implement the Medicare bundled payment program. It's a lot, right? It was overwhelming to even just say it. But it was a very interesting exercise because I learned the hospital and the post-acute side. That's basically home health and skilled nursing and things I didn't know existed, right? Like IRF and LTAC, what's that, right? And then Humana, which is a national health plan, quickly recruited me to oversee contracting and network management for Hawaii and Nevada, parts of California. And I learned contracting and network management, and I was now on the health plan side. And on the health plan side, I really got to see what the leverage points were, and really what the incentives are. How do we align those incentives? And so while I talked about 28 clinics, 14 hospitals, and so on, those were milestones. And by now I've had, over 5,000 providers I've managed and so on. And so the important thing is to realize that as an emerging leader, now, whether you're a healthcare, entrepreneur or star, we all want to make sure we understand where we are in the ecosystem. So what happened is I left Humana to embark on a healthcare infrastructure development journey. Of course, everything in healthcare has a long title, and this is not an exception to that rule. And essentially, that Carenodes is such a, we're leading that initiative by establishing the framework within which the healthcare ecosystem can be orchestrated. And, this is not a Carenodes presentation, but I want you to kind of have a high level understanding of where Carenodes stands. There are some terms and conditions participating in this call. If you do not agree to these terms and conditions, please go ahead and drop off the call right after I share these terms and conditions. So foremost, Americans deserve leaders that get it, Okay. We don't want to create technology for the sake of technology. Please stop that. We don't want to be out there not knowing what we need to do, right? We need to be serious, you guys. We need to take our responsibility in a way that's solemn and serious. Now, healthcare is very opaque, right? And so we specialize in demystifying healthcare. And, Nichiren Daishonin, who was a Buddhist monk back in 12th century Japan, indicated that even a cave that has been in total darkness for millennia will become instantly illuminated the moment you spark a match, right? So the minute you have that spark of a match, the entire place becomes illuminated. And that's what will happen this very minute. If you agree to terms and conditions, otherwise please drop off. We have clinicians place an oath, do no harm. As a healthcare administrator, you now take that oath, otherwise drop off the call. You do no harm. It's very easy, you guys. As you grow, you will be seeing numbers. You'll see more and more numbers. You'll see, as the Excel sheet will have, 8, 9, 10 figures. It's very easy to forget that these are patients. Do no harm. Be empowered. Be empowered to speak up on behalf of the patients. Know your place, but be empowered. Take personal responsibility. If you see something is going wrong, if you see Medicare, just, you would know what responsibility is. This is about flow of funds. I'm not going to go into that. Be solemn about your role. Realize that you're important. No matter what it is that you're doing in healthcare, you play a part in this huge multi-trillion-dollar enterprise. Realize healthcare is personal. So when we talk about scaling and standardizing across, systems and this and that, yes, we can have standardization, but once it gets down to the last mile, once it gets to the patient, you have to realize the patient has cultural differences, economic differences, market differences. So please be sensitive to that. We cannot be automating, whatever it is that we're thinking about automating and not realize that that patient could not be, responsive to that robot, right? And now we've made the situation even worse. Please do not disrupt healthcare, construct healthcare, and calibrate your moral compass. Ask yourself, anytime you want to make a decision that's exciting you because there are dollars involved, let's say that's how you're motivated, ask yourself, is this decision in the best interest of the patients? You'll know the answer. If not, adjust the strategy and still you can hit your dollar mark. And that's from Dr. Brenda, freshman at CSU. So if you agree, great. If not, please get off the call immediately. And now those who have agreed, thank you for remaining. This is what you will benefit. These are the benefits from your acceptance of these terms. You will have an unfair advantage now in the workforce. If you're an entrepreneur, if you're CEO of a health technology company, you will have an unfair advantage in your go-to-market placement. Congratulations. You'll be able to accelerate innovations. That's what we do here at Carenodes. We've been accelerating innovations during COVID because we've been able to exercise the waivers and bring the, otherwise tech companies into healthcare organizations so that they're able to are actually able to bring their innovations into healthcare versus, just being an idea and not sure how to get a contract with a health plan or provider, because these people, they come from Nokia and Snapchat. They know coding, but they don't know healthcare. Same here. I come from healthcare. I don't know coding or Snapchat. I do drag and drop, right? So we've been able to accelerate that. Bending the learning curve. So we want to make sure that the learning curve is in such a way where we already kind of talked about bending the learning curve. Providing a framework so you understand exactly where your company stands in terms of getting your first contract or your next contract and so on. I know we have several of our startup executives here on this call. And that's why you'll hear a startup. But when you do, the healthcare administration students, the clinicians that are on this call, realize that this also pertains to you as you're in the workforce. So we start from a place of darkness. Let there be light, let there be Carenodes, and let's go right into it. Any healthcare organization, you guys, now we're on the 6 functional areas. Tammy, I know you're driving, so let me explain the visuals we're seeing. There are 6 functional areas in any healthcare organization, no matter whether you're a 90-year-old, endocrinologist on the island of Maui practicing out of your, townhouse, basement is the clinic, Upstairs is your, bedroom, and I've seen that provider. Or you're a multi-billion-dollar enterprise like Humana or any one of these other giants. You have 6 functional areas that you have to, have in place. Sometimes, one person wears all hats. Other places you have, 18 people wearing half a hat. So what are the hats? Operations, profit and loss. Anything that is profit and loss is under operations. You need leaders for each of these segments. Compliance, self-explanatory. Health services is basically the medical director's wheelhouse. Like if you're at a health plan, that's utilization management. If you're at a clinic or provider side, that's basically the medical director's area. Engagement is like marketing, outreach, sometimes grievances and appeals going to engagement, patient surveys, and so on. Contracting and network, which is what we're actually going to talk about today, that's managed care. So we're going to expand on that. So if you're on the health plan, you need to obviously have contracts, right, to have a provider network, because there are regulations that require you to have a provider network in order to sell health insurance products to patients and then have the patients go and use it, right, to the provider network that you contracted. And quality. So quality, we all hear about, value, quality to, value, volume to value. And quality is basically looking at those measures. And there's 2 categories. There's patient experience, which is the patient's subjective reporting of their interaction with the health system. And then there's clinical outcomes, which are objective measurements of whether my blood pressure has been improving or not, whether my blood sugar has been improving or not, things you can actually, measure objectively. And then you have a whole host of subcategories under these 2 umbrellas. It's different from health services because it's not direct care delivery. Instead, it's kind of post-care delivery, measuring how the care was delivered. So if you're looking for a job, you're trying to understand where you should look in terms of, okay, what am I interested in now? I'm a healthcare administration master's student or whatever. Where should I place my technology? Who should I approach at the, hospital or at the health plan? Well, what solution are you providing, or what are you interested in doing? Here's a framework, and you can target one of these and go into, that space. Now let's zoom into the contracting functional area, contracting network functional area, which is really managed care. What is managed care and what does that mean? So managed care is insurance company. It's the insurance world. Why? It's just exactly what it sounds like. Manage care. So basically, they want to go ahead and manage the cost. That's what AKA means, managing the cost. Okay, and so a managed care department deals with the payer-provider contracting and everything that deals with those elements. And a robust, a well-functioning managed care department under robust leadership and a good program has these elements. And essentially, I'm going to go briefly. So you have, credentialing, you have elements you need to understand, the billing and obviously payer contract negotiations. You need to be able to understand, in a group that's more than one physician, let's say, okay, where are you going to get those other physicians that, let's say you want more than one, right? Those are the rendering providers. Network development, where are you going to go ahead and, get your referrals from, and demand generation. So managed care department is responsible for getting contracts, making sure all the physicians or providers are credentialed, meaning that they're able to see, patients who are in network with the contracts you just got, let's say with Blue Shield. Dr. Jacob has to be in the Blue Shield. I don't know if you guys can hear that, but has to be in the Blue Shield network in order for, for instance, to be seen by that patient. So essentially what it is that I want to now go into is kind of take this managed care department and translate it into the model that we've been using to bring healthcare startups to market. And basically, now that there are these COVID waivers, you could get a Medicare enrollment very quickly. And we're plugging and playing. We have a plug and play kind of managed care department, and we're kind of being stewards of health technology coming into healthcare in a way that is responsible. Remember the oath and the terms and conditions? That's what we're doing with the health technology companies, bringing them to market within 6 months. Now, what you need to understand is where the money is coming from. We already covered the managed care mindset. Remember, so I said managed care is cost control, payment. We talked about how we're moving towards value. That's what there was a quality segment. And I talked about the two major quality umbrellas, which is really patient experience and clinical outcomes. So if you were to be in a traditional class or a course taught by non-Carenodes, what you would see, someone would try to explain what you're seeing on your screen, which is what the system is today, which is a multi-payer, multi-purchaser. So these are multi-payer, multi-purchaser, multi-provider, multi-processor system of healthcare delivery. So let's unpack that. Let's open that up and let's essentially have a playbook to trigger the dollars. And so I'm not going to go over this slide because there are too many lines on here. If I was on your side, I would zone out here. So let's move forward. Let me paint the picture for the ACA or aka Obamacare, just so you have an appreciation for what's to come next. Before 2014, January 1, 2014, there was no Medicaid expansion, which you'll see in the next slide, which will make sense. So basically, if you didn't have an employer, you didn't have any insurance unless you were either pregnant or disabled. Done. Okay. Or if you had pre-existing conditions, you couldn't really afford insurance, and pregnancy was a pre-existing condition. That was 2014, not long ago, you guys. It was a luxury. Healthcare was a luxury. Now it's a privilege. So here's healthcare financing. Imagine me having to go through this. Yeah. So this is a more simple version of the thing you saw. So there's, obviously public financing, private financing. Again, this doesn't really help many people. This is what's helpful. So look at these buckets up here. So this is the top line bucket. So I want you to first understand the basic language. So when you're, doing an interview, or when you're, putting together a business plan, or speaking with, your counterpart at a health insurance company, the executive you're, wanting to, last thing you want to do is talk to a health plan executive or, a healthcare executive and you try to tell them about their business, right? You want to speak their language very quickly. So you have to understand the buckets first. The buckets here are the highest level of funding, right? And you'll see these buckets, actually, they have different balance sheets. And the different balance sheets, they're different because the dollars come from different places, different sources. That's why the single payer discussion is, you'll start to see how that's kind of, how would you do that, right? So again, different topic, but let me explain. So the bucket of Medicaid, it's for the Medicaid line of business for those who are below certain poverty line. So remember what I just showed you, the ACA expanding Medicaid? Before it was poverty line, pregnancy, disability. Now it's poverty line. So in California, if you're 139%, which I don't even know what the dollars are on that, you could look it up. But basically, I think it's $25,000 or less per year for an individual. Then you could get Medi-Cal, which is a California version of Medicaid. So Medicaid is run by the states, right? So it's partially funded by the federal, and then state has to fund the rest. Now, each state, so now you have 50 Medicaid, the 50 different Medicaid programs. Now you're starting to first get the first picture of why there cannot be a single payer. Okay, so you have 50 different Medicaids, right? In California, it's Medi-Cal. And so let's talk about Medi-Cal because I'm not sure how many out of states we have here. So Medi-Cal essentially is for anyone who's low income. So if you think about Medicaid, think about aid, right? You're giving aid to those who are low income. Medicare is for those who are 65 and above. It's retirement, right? There are certain exceptions, like if you have, there's certain exceptions. Let's not worry about those, or a fraction of Medicare. But Medicare is for those who are 65 and above. So think about Medicare, caring for frail and elderly, right? So Medicaid, I'm going to help aid you. Medicare, I'm going to care for you. Commercial is essentially a catch-all term for anything that's not Medicaid or Medicare, right? So these two programs are government funded, Medicaid, Medicare. Commercial is the employer funded product. Now, there's an exception. So essentially, off exchange, remember when I talked about the ACA, the Obamacare or ACA Act created what's called marketplace exchanges, where remember previously, I'm going to go back 2 slides, where it says previously, pre-ACA, no employer, no insurance. Well, post-ACA, where there no employer, well, you get insurance through the exchanges, which in California, it's coveredcalifornia.com. So each state has its own health insurance exchange. And if not, then the federal does. Let's not worry about every different state. But what I want to point out is that the commercial insurance is available to those who do not have insurance through their employer, but do not have an income that's so low that justifies Medicaid. So if you don't have insurance, right, and let's say if you can't get Medi-Cal here, you go to coveredcalifornia.com and you could get one of these on exchange, policies, and you could put deductions, and then you'll get a subsidy. So like a plan that would have like a premium of $350 a month, like let's say a Kaiser plan or a Blue Shield PPO or whatever's on that exchange, they have to be approved. There's regulations around them. You could get a subsidy, right? Like you can get assistance. And then at the end of the year, the tax person will actually look and be like, oh, okay, you made more, you made less, and then they'll do an adjustment at that point. But your monthly premiums could literally be like $5 because there's a subsidy. So commercial here, that on exchange is partially government funded, but this off exchange is fully private. So it's your employers and it's you who are shelling out the bill for them. This employer benefits thing is, it's employer kind of HR benefits. Like let's say you're having an issue, they'll authorize 3 therapy sessions, and it's a new kind of, it's not new, but it's showing up more and more because the employers they pay much less. It's very cheap for the employers to do EAP. And as a provider, it's very disadvantageous for you to do that. And then going next, you have Medicaid and Medicare, and those are patients who are both, under the poverty line and frail and senior, eligible for Medicare, so over 65. And those are called duals. And then underneath these duals, you'll see many, many different types of plans. This is impossible to list all of them, but these are the common ones. For instance, severe needs plan. So there are special plans if you have diabetes. They're called D-SNP, I-SNP. Don't worry about all of that because this is 101, right? What's important for you to know is lines of business. These are the flow of funds. So for you to know, okay, if I'm going to place my business if you're going to position your business, you really have to know where in the spectrum are you going to place your business, right? Or where do you want to work within the spectrum? Now, these are lines of business that are at the highest level. And then you have what's called products. The products are packaging, right? So you can have a Mercedes, let's say, that is a model, S. This is an impromptu example. Same thing here. Maybe it's not a great example. Let's just use these examples. You can have Medicare PPO. You can have Medicare HMO. You can have, in California, you can only have Medi-Cal HMO. That's like I said, it's a state run. Every state has its own. And I'll leave room for Q&A if you guys want to know. I'll answer those questions. But basically, what it is I want you to know is the line of business is important because these are technically different spreadsheet, different balance sheets, right? So you want to understand that every time, like as a healthcare entrepreneur, you have to realize that these are different revenue streams for you. You cannot think of, okay, I'm going to see patients. Okay, which type of patients, right? So that you can actually understand the financial picture. And what type of products, because they have different administrative costs and top line revenue implications. So essentially, now going to the product spectrum, the low to high, what this means is the restrictions. So fee for service is the lowest restricted product, meaning it gives a customer greatest freedom. And HMO, it has the highest restrictions. which means the least freedom. Now, these acronyms are fee for service is exactly what it sounds like. So number of times I poke you as the provider, the number of times I get paid as the provider, and the patient could go wherever. For instance, Medicare fee for service, like a Medicare, not through Humana or not through Aetna, any one of these private companies. I could go wherever and give them my card and then get seen. I don't need any authorization. I don't need anything like that, right? PPO is basically a network. So let me explain. Medicare fee-for-service does not require that the provider be contracted. There's no contract with Medicare fee-for-service, original Medicare. That's directly through the federal original Medicare. There's program enrollment, meaning even if a provider is a non-participating Medicare provider, that provider could still see a Medicare patient and get reimbursed for that patient. In fact, they get reimbursed at a higher rate. That is a fee-for-service model on the Medicare, original Medicare side, because Medicare patients have choice. Unless they enroll with a health plan like a Humana, Aetna, this and that, they relinquish their choice and they become one of these PPOs, HMOs, and so on. You're with me. So the PPO is Preferred Provider Organization. Why they call it that way and unintuitive, I'm not sure. But Preferred Provider Organization basically says, okay, patient, the patient buys an insurance plan that is consisting of a network of providers that are contracted, and they've contracted, signing a deal with the insurance company saying, okay, I'll take a discount in exchange for volume. Okay, so I'll take lower rates than what I would get if I was not in network with that insurance company as a healthcare provider, in exchange for more patients, because my name is going to be on their website, right? So if a patient goes to one of those doctors that are on the directory, then that patient's going to pay lower copay or lower coinsurance, right? Now, because it's a PPO plan, that patient could go to a physician or a provider that is not on that directory, because it's in the name, preferred provider. So if you go to the preferred providers that are contracted, you pay lower this copay. If you go to someone who's not in that network, then you pay a higher copay as a patient. So it could be 40% versus 20% of the cost, right? Again, it's to restrict, right? Managed care is to control. So you could see the controls are starting to get tighter as we go, further in the spectrum. POS is point of service. So basically, POS is a hybrid between this PPO and this HMO. Basically, the patient at that point of service gets to decide, okay, I want to go to a provider that's not in this network and I'll pay more. Or, oh no, I want to go to a provider that's in network and I'll pay less. POS products are increasingly diminishing, so don't be stressed about them. The EPO is also, I'm seeing less and less of that. But essentially, EPO is exclusive provider organization. It's kind of like the PPO, where you have that contracted, network of providers who are on that list. But it's unlike PPO in the sense where if you go outside of that list, then you cannot get, you have to pay the full price as the patient yourself. The HMO, you cannot go in or outside the network, and you can only go to the provider who's your primary care physician, who's on your card, insurance card, and then that person will direct as to where you will go. And that's the highest level of control in this managed care. So you see, the buckets, the lines of business fund the pool, and then the pool's packaged in different ways. And then in these different ways. And then the patient selects, one of these products. And the thinking is that if patient selects a PPO product, that patient wants to go wherever they want to go. So they're going to be costing more. So then their cost, the patient's cost is going to be more, and their premium is higher. So let's go to the next slide. You'll see. I should probably have gone to this slide first. But here you could see this. So least restriction means more cost. And least cost, most restriction. Restrictions and controls, meaning authorization, referrals, and you name it. Denials. I'm not going to go too much into this because this is maybe like 102. But this is to explain there are different types of commercial plans, even under off exchange, on exchange, under exchange, above exchange, dancing with exchange. Healthcare is complex. So you have to know what it is that, what it is that you're targeting, what you're dealing with. Again, this is a little bit out of the scope of this discussion, but it's here to kind of break down the buckets of funding a little bit further. So, for instance, here where I'm showing my this cursor, you see off exchange, on exchange. Seems simple because we're simplifying, but then there are nuances here. But essentially, here I'm making the point that on exchange commercial has some government funding, and every time you hear government funding, know that there are regulations. So if you feel like there's something that's happening with the insurance that doesn't seem right, look up online, see what the regs are. Go to Department of Insurance, DOI in California, Department of Managed Healthcare in California, DMHC. Again, this slide we're not going to go over, but basically, and then I go. But basically, like I stated, some states have expanded their Obamacare ACA into state administered. Others haven't. And over here is the states that have state administered exchanges. And those are the states that have also expanded their Medicaid. And if you're making business decisions, or if you're wanting to, let's say, for instance, Oscar Health Plan was interviewing me, I don't know, like a few years ago. And they wanted to start, doing a network in California, and they wanted me to be the California contractor. And they were wondering, how I would how I would negotiate this, deal with a certain hospital. Sorry. And I asked them, okay, how many patients do you have? And they literally had no members. And, you need volume to be able to negotiate the way that I was being told that they want me to negotiate. You also need to know the risk and the volatility. So let's say you are wanting to implement a business plan, right? And you need to gauge your effort against the yield and the volatility of the market you're going after. I hear often that, we want commercial patients only because it sounds good. Commercial, right? Sounds concierge, sounds nice. In fact, and actually this was created before the election. So, next year I'll reconsider the positioning of this segment of the business. But essentially, Medicare has the least effort in implementing essentially contracting. If you're trying to have revenue, seeing Medicare patients is going to be the least effort and the highest yield and the least volatility. You guys realize that there are 10,000 Americans aging into Medicare a day. That started in 2012, and it's going to a same growth rate until 2030. It's like, it's self-explanatory, right? So it's going to have the least volatility. You're not taking Medicare away from Americans, even when the dollars run out. You can. Cash. There's a huge emergence in cash business simply because the commercial employer plans are becoming too expensive. It's untenable. If I have to pay a deductible of $5,000 before it hits insurance, I'd rather pay $100, on a monthly basis to see a therapist, versus paying $200, or whatever the cost might be with my employer plans. So I want you to consider this slide as you do business strategy. And mix your revenue stream or payer mix in a way that would reflect market volatility. Again, we kind of went over this. This is another depiction. I'm going to first put a plug for HCAT.
HCAN is the Healthcare Administration Alumni Network, which is an alumni networking group in support of the CSULB, Cal State University, Long Beach Department of Healthcare Administration. Through various events, programs, and services, we develop leadership and professional growth. We provide networking opportunities, industry awareness, really staying connected with peers. This network is led by a diverse group of alumni representing both the bachelor's as well as the master's degree programs in the healthcare administration programs across the sector. So, from the acute care hospitals to managed care organizations to healthcare consulting firms, come to the association and be part of a network which is, characterized by its standing in the industry and its ability to really be a mentor and grow together.